Hello, my name is Daniel Forman. I am a cardiologist based at the University of Pittsburgh and the VA Pittsburgh Healthcare System. And in my clinical and research work, I have strong ties to cardiac rehabilitation and heart failure. So I am here today with Gordon Reeves, my colleague and friend, to discuss cardiac rehabilitation and the recently published trial Rehab Heart Failure. Gordon?
Hi, I'm Gordon Reeves. I'm a heart failure cardiologist working at Novant Health in Charlotte, North Carolina. I also have a background as a physical therapist, and like Dan, have been working in cardiac rehab for heart failure patients and other rehab interventions for heart failure patients as my primary research interests.
So to introduce this topic, I want to emphasize that cardiac rehabilitation overall is a multifaceted program that provides education, healthy lifestyle that includes both diet and physical activity. It focuses on exercise training and risk factor reduction, stress reduction, and medication adherence. Again, multifaceted. And eligibility to cardiac rehabilitation includes coronary artery disease, revascularization, both CABG and PCI, and it has expanded over many years to include other types of cardiac disease, including transplant, valvular heart disease, heart failure, particularly heart failure with reduced ejection fraction, and peripheral arterial disease. It's also notable to me, and I think to the cardiology community, that in this post-COVID environment, cardiac rehabilitation is in a dynamic phase of development, particularly in respect to new models that are developing that involve telehealth modalities with the notion of remote-based cardiac rehabilitation, hybrid-based rehabilitation, and various types of exercise training regimens. So with that kind of broad context, I want to talk a little bit more about the inclusion of HFrEF into cardiac rehabilitation. And that was relatively recent. It really happened after CMS was granted approval in 2014, and it was premised particularly on heart failure action, a trial that was a landmark trial showing the safety and the benefits of exercise training for patients with heart failure with reduced ejection fraction. It involved primarily aerobic training for patients that were stable with chronic HFrEF. And exercise training was demonstrated to be safe. That was a big issue. And it was a site-based supervised format for the first 3 months, followed by a home-based exercise thereafter. And the benefits were multifold. It included reduced cardiovascular disease mortality, improved function, decreased rehospitalization, and many qualitative benefits, quality of life, and the favorable effects extended to women and the very old. And so the Rehab Heart Failure trial, which was published much more recently in the New England Journal of Medicine, showed benefits with a very different type of exercise training regimen with different types of patients for acute heart failure. And so Gordon will now describe the trial, starting particularly with the study population.
Yeah, thank you, Dan. So this, as you pointed out, HF Action was really the background that helped get us started. And as you mentioned, focused really on the chronic stable outpatient, which establishing safety with that lower risk group was important. With Rehab-HF, we switched the focus to the acute decompensated heart failure patient. This population had been excluded from prior cardiac rehab trials because of the safety concerns from a recent exacerbation of heart failure and the high rates of events associated with these patients. 50% of them are readmitted or experience a death within 6 months of their hospital discharge. They also are the most debilitated population. So in some of our early studies, we found really broad-based functional impairments and much more severe than those seen in, for example, the HF Action population. Including deficits in balance and mobility, increasing the fall and injury risk, and even just functional strength, like simple things like getting up out of a chair. About a quarter of our patients couldn't do that without assistance from someone who are using their arms. They lack the leg strength. And a common metric that most used in cardiac rehab, the 6-minute walk test, it was roughly half that seen in the HF Action population. So really a very debilitated group and high rates of frailty. The majority of patients met formal frailty definitions, and almost all of them had at least some features characteristic of frail patients. So really a very different population, higher risk, but we thought potentially higher reward as well.
Gordon, do you want to talk a little bit about the actual intervention?
Yeah, so the intervention really grew out of what we identified as their deficits. And because their physical function impairments were so different from prior rehab populations, at least in the heart failure literature, we thought we needed to really modify the intervention to match that. We enrolled them in the hospital and got them started on the rehab as soon as they could. We targeted within a week of discharge and actually got them started on average within about 10 days. We followed the familiar 3 days a week, 3 month kind of structure, but that's really where I think a lot of the similarities with the more typical cardiac rehab and beyond that, our intervention was quite different. Most notably, patients were not in a group session. They were one-on-one. We included physical therapists because of the balance and mobility deficits. They were part of our rehab team. And we made the intervention target all of those domains that we had identified, the mobility, the balance, the functional strength training, in addition to endurance. And we really tried to focus on the balance, mobility, and strength first, so that when we moved on to endurance, they would be at less risk of falls and could do that more safely. We also created a very structured progression. These patients are very debilitated, and the typical intensity metrics we use in cardiac rehab aren't a good fit. And so we created a very detailed, structured progression to make sure that they were continuing to make improvements and progress over the course of the rehab in each of the domains. With that, I think found some pretty exciting results.
So I want to ask you about the results, but before I do, for the audience, I really want to highlight that rehab heart failure is not cardiac rehabilitation. You mentioned one-on-one and a very intense kind of a training regimen that is really very different than the model of a group-based exercise session in traditional cardiac rehabilitation. But it provides important kinds of principles that may be very applicable to a future form of cardiac rehabilitation or care in general for an older population that tends to have cardiac disease or with frailty and elements of complexity that were not typical of perhaps of cardiac rehabilitation in the past. Do you want to talk a little bit about the outcomes, Gordon?
Yeah, thank you. The study was really a phase 2 trial designed to assess improvement in physical function. Our primary physical function endpoint was something called the short physical performance battery, which is very common in the geriatric literature, starting to make gains in the cardiac literature, as you said, with recognition that we're increasingly dealing with older, frail patients. And so this captures 3 domains: gait speed, repeated chair rise, and a standing balance score. And with that, we saw significant improvements in physical function. It's the SPPBs on a 0 to 12-point scale. Our patients improved more than 1.5 points, which is about 3 times the minimum meaningful change, and one of the largest effect sizes that's been reported in the literature to date. In addition to physical function, we also saw in the SPPB, we also saw improvements in 6-minute walk by over 30 meters, and improvements in quality of life, including through the KCCQ, as well as a reduction of symptoms of depression.
So again, I want to echo the point I made before. This is not cardiac rehabilitation that you're going to put onto your iPhone and have telehealth models. It's not ready for hybrid and remote. We're not there. So if the audience is familiar with contemporary cardiac rehabilitation evolutions, it is not rehab heart failure, at least not yet. But yet it still provides some very important principles for the future.
Yeah, just to echo that, it was very hands-on. The one-on-one rehab was partly to make sure we're constantly progressing, but also for patient safety, making sure there's no falls, and closely monitoring how well they're tolerating the activities. And we thought that was one of the keys to the study's success. We were not powered to really assess for clinical events. So although the results are very encouraging, we're very excited by them, we think it warrants further study. There were less than 200 patients exposed to the intervention. We think we need to study this again in a larger population of patients, and one that's adequately powered to better assess both safety and efficacy. And I will add too, another distinction from a lot of prior rehab trials that had focused on reduced EF, we included the HFpEF population. About half of our study had preserved ejection fraction, the other half had reduced. And we subsequently have compared those two. They both improved, but if anything, the preserved EF patients seem to improve more and respond better to this intervention. So going forward, that's really the population we plan to focus on to see if we can improve clinical events.
For my last comment, I just want to emphasize that notion of proving efficacy of exercise for HFpEF is kind of the holy grail in the exercise cardiology literature. And I think there's lots of reasons to think it will be favorable. And certainly the preliminary data from rehab heart failure suggests a very strong benefit from this approach that is being promulgated by this trial.
Yeah, I agree. And we're very optimistic and look forward to doing that. This is a population of patients who don't have a lot of other therapeutic options. So we were particularly excited to see that they responded well to this and hope we're able to study it more.
Thank you very much.
Thank you.